Good afternoon. Welcome back from lunch. My name's Vanilla Gill and we've got Joanne Harmon. We're chairing the session this afternoon, which is What's New in Research, and we've got 4 presenters and they're going to each speak and then take some questions at the end of their talk. We'll do one at a time. So, Joanne, I'll introduce the first speaker.
Okay, first up we have Professor Jason Roberts. Professor Jason Roberts is a National Health and Medical Research Council practitioner fellow at the University of Queensland, and he's also a consultant clinical pharmacist at the Royal Brisbane and Women's Hospital. And he's going to be talking to us today about antibiotic dosage in critically unwell Indigenous patients. Thank you, Jason.
Thank you. So, given the topic of what's new in research, specifically relating to pharmacokinetics, there's actually a lot of information that exists in this area, and a lot has happened over the last 2 to 3 years. So what I thought I'd do is I'd focus on something which is truly unique and having been done in Australia, and that refers to a series of studies that we were lucky enough to collaborate with Alice Springs Hospital, looking at better ways to dose antibiotics in critically ill Indigenous patients. Now, this was a really important area of research for us to undertake because there was no pharmacokinetic studies describing what dosing requirements for antibiotics would be in Indigenous patients of any kind, let alone critically ill patients. And so this was deemed to be something identified by Danny Sy, who's a pharmacist at the Alice Springs Hospital. This was his PhD topic. Something which he deemed to be of great importance to the practitioners there at Alice Springs, and so it was a great pleasure for us to contribute to this study. So I'm really presenting on behalf of Danny and just summarising all of his work, and it was a fantastic PhD, as you'll see. So for this audience, we all know that in critically ill patients that infections are responsible for a huge level of morbidity and mortality, and certainly there's increasing data to suggest that optimised antibiotics is a key intervention. Most of the data certainly surrounds the choice of antibiotic, but there's now an increasing level of data which is showing how important dosing is, so getting the right exposure or concentrations of the antibiotic in those patients. Because if you can do that, you can increase the rate of bacterial killing, allow the patient the opportunity to recover from the pathology caused by that infection. So knowledge of pharmacokinetics here is something which is very important. Now, for those of you that don't necessarily know what pharmacokinetics is, it really is just that relationship between the dose of drug that's administered and the concentrations that result. And so for treating an infection that we need to have a certain concentration of antibiotic which is able to kill that bacteria, then if we know the pharmacokinetics or that relationship between dose and concentration, then we can choose better dosing regimens. And so that's why pharmacokinetics is so important for antibiotics. Now, the reason that in critically ill patients that this is of particular importance is has to do with where dosing regimens come from. So in the product information, there'll be nice dosing regimens which describe for a particular level of renal function what sort of dose should be used for that antibiotic. But that dosing regimen has never been validated in critically ill patients, and that is obviously highly problematic. So if we think about where dosing regimens come from, just quite briefly, that in some very controlled animal model studies and laboratory in vitro infection model studies, the exposure or concentrations of drug that are required to kill bacteria are defined. Then there's some testing which is done in healthy volunteers to make sure that we can achieve those concentrations in people. And then once we know that we can achieve those concentrations and the pharmacokinetics in a human model, then we can test them in a relatively well cohort of patients in the hospital. Never, though, are critically ill patients included in these studies, although that is something which has changed in the last 5 to 10 years. But certainly for most of the dosing regimens that exist, we don't have this validation that these dosing regimens that are tested here are actually appropriate for critically ill patients. And where this is problematic is this range of pharmacokinetic changes that can occur in critically ill patients, which make them a much more special scenario compared to a patient on the ward. We can have this broad range of pharmacokinetic possibilities. We can have patients which have retained organ function, become very hyperdynamic, and because they are so hyperdynamic and they have retained organ function, they get increased perfusion of their eliminating organs, increasing delivery of drug to those organs per unit time means increased clearance of drug and therefore lower drug concentrations. At the other end of the spectrum, of course, we have patients that develop single or multiple organ dysfunction syndrome, and if that's associated with an organ associated with clearing of the drug, then of course that clearance doesn't occur, and so you end up with higher drug concentrations. And of course, if a patient requires any form of organ support, ECMO, renal replacement therapy, whatever it may be, then that can have another less predictable effect on antibiotic concentrations. And so if you think about all these possibilities that can occur for affecting antibiotic concentrations, then trying to procure a dosing regimen for a critically ill patient is something which is quite challenging. And even here, we haven't taken into account the effect of the race or the background, the ethnicity of the patient. So this is where Indigenous patients become quite interesting. A lot of the data that currently exists for it suggests that patients that come into hospital, if they're Indigenous, are more likely to die, and the likelihood of them dying from sepsis is also higher. They're far more likely to be admitted to hospital because of sepsis, and far more likely to be admitted to the ICU as well. So when we try to think about is the behaviour of a drug, so the pharmacokinetics in one patient population, so we might look at it at this stage from an ethnicity perspective, is it the same in one group versus another? We can compare pharmacokinetic studies which have been done in those different patient groups. And so here I wanted to just show you some of the preliminary information that we got from one of our review papers that we did before the pharmacokinetic studies that I'll describe later. And here we're looking at the drug ciprofloxacin, which I'm sure a lot of you will know about, in an Indonesian, Brazilian and German Caucasian cohorts of patients. And what was shown here was with patients receiving the same dose, that the area under the curve, which could be considered this measure of the total exposure or measure of the total concentrations that are observed in patient, was far different, up to threefold different in fact. And so this suggests that there probably is an effect of race for some drugs in terms of what is contributing to altered pharmacokinetics, and developing a better understanding in individual ethnicities is something which is important. So what about renal clearance? Well, this is one thing which I'm sure a lot of you know, that Indigenous patients or people generally have a greater likelihood of having chronic kidney disease, and that's something which has been very well described in many patient groups. Certainly in this epidemiological study that was performed here, in the Northern Territory in particular, the likelihood of a patient having chronic kidney disease was 32% versus for a non-Indigenous patient only 8%. So it's something which is quite a significant issue, and it tends to be that the more remote is the location of where the patient or the person lives, then the higher the likelihood that they're going to have chronic kidney disease as well, introducing problems associated with predicting what their needs will be from a drug dosing perspective when they do make it to hospital. One issue which has been increasingly described in critically ill patients is that of augmented renal clearance. Now, this is defined as a creatinine clearance greater than 130 ml per minute, but although that can be described in terms of just a yes-no, it is obviously on a continuum, and so patients that can have creatinine clearances as high as 300 ml per minute, as we've shown in some studies. What has been described in other patient groups to date is that the main risk factors for developing augmented renal clearance, and the reason this is so important, of course, is if you've got a very high drug clearance, you have a very fast removal of drug and then very low drug concentrations. But presence of trauma, major operation, being male, low age, and presence of sepsis and critical illness are associated with augmented renal clearance. These are studies which have been done in non-Indigenous patients to date, and is certainly something that we wanted to look at in one of our later studies that I'll describe about what the risk factors are for this in Indigenous patients. So we're trying to describe here at this stage the likelihood of the prevalence of chronic kidney disease and the prevalence of augmented renal clearance in critically ill patients. So in terms of trying to describe what the types of renal functions that there are in Indigenous patients, we did a study called the Croc study, which was essentially looking at prevalence of creatinine clearance measures, specifically a measured urinary creatinine clearance, and 130 patients were recruited in this study, all conducted at the Alice Springs Hospital. Trying to compare the demographic characteristics between the Indigenous and the non-Indigenous patients. There were significant differences which tell a lot about the type of patients that do get enrolled into their intensive care unit, but the Indigenous patients tended to be much more likely to be younger, and also were more likely to have a lower body weight than the non-Indigenous patients. When trying to describe the difference in the presence of augmented renal clearance, it was found that 32% of patients who are Indigenous manifested augmented renal clearance. A lot of this is likely to be due to the lower age of those patients, and it was only 20% of the non-Indigenous patients. For acute kidney injury, if this is the bottom row here, it was more common as well in the Indigenous patients too. So they certainly have a greater spread of renal functions more consistently in those patients. When we try to measure what the determinants of augmented renal clearance are in those patients, then it tends to be very similar factors to what we saw in the studies which have been reported in non-critically ill patients. Age, presence of surgery, and also morbidity. This is just another study describing, another presentation of that data, which I'll just skip through. In terms of what's the most suitable estimate of GFR, noting that performing a measured creatinine clearance is something which isn't consistently done, it's considered largely that it's the CKD epi equation or the Cockcroft-Gold equation performed with total body weight. And that's these two graphics on this side here show that you get less bias with increasing values with those. So I wanted to very briefly talk about some of the pharmacokinetic data that was derived from this work from Danny. Here he's got a slide referring to the pharmacodynamic characteristics of antibiotics, and specifically we're focusing on beta-lactams, which are time-dependent antibiotics, so maintaining concentrations above a certain value throughout the dosing interval is what's considered to be required. For meropenem, here we have what we call a probability of target attainment graph. So this is the likelihood of achieving a therapeutic exposure from 0 to 100% versus an increasing MIC. So this is a measure of susceptibility of the bacteria to the antibiotic. And this is for 4 different renal functions, 20, 50, 130 and 170. This dashed line here represents what the MIC breakpoint would be for this drug. And as you'd expect with lower renal functions, that all dosing regimens achieve the right exposure, but with these patients that develop augmented renal clearance, they're far more likely to not achieve that exposure with standard dosing. And so with this, we were able to propose a nomogram for dosing of meropenem in critically ill Indigenous patients. For piperacillin and tazobactam, exactly the same effect that we see here with increasing renal function. Again, at the highest renal function, you have a lower likelihood of achieving the therapeutic exposure at the higher MICs, and therefore we were able to propose a nomogram as well for dosing these for piperacillin and tazobactam as well. Ceftriaxone's a little bit different because it's a highly protein-bound drug, and it's the unbound concentration which is of principal interest to us here. And we found that with standard dosing for critically ill patients of a 1 gram 12-hourly dose, that this achieved therapeutic exposures, and so no dose adjustment is generally required for ceftriaxone unless the patient has severe renal dysfunction. And then we're also able to develop a vancomycin dosing nomogram, again based on a weight-based loading dose and a maintenance regimen based on the patient's creatinine clearance. So that's very similar to what has been shown in non-Indigenous patients, but the values for the different renal functions and body weights tend to vary a little bit. So in summary, individualising antibiotic dosing is very important. This data, which has been obtained at the Alice Springs Hospital in collaboration with the University of Queensland, I think is something which is very useful, is able to influence local practice, but also practice for others that care for these unwell patients. What would be very nice in the future is to do a study which looks at how personalising dosing in these patients can then lead, whether or not it leads to better patient outcomes. It's certainly something which I think is very important, and we look forward to more studies coming in this important patient group. Thank you.
Do we have any questions for Jason? Can you wait for the microphone? Hang on. these sessions are being recorded, so that's why we're using the microphone.
Rajiv Hegde from Royal Brisbane Hospital. I work with Jason day to day, so I know him very well. Jason, I thought that the data there is same as any other patient, effectively. Like Indigenous or non-Indigenous. I'm just looking at that and I'm feeling that whatever we're doing at the moment in our practice, where we don't have that many Indigenous patients, we should basically practice the same if Indigenous patient comes in. Is that reasonable to say?
It's not quite the same. The principles are unchanged, though. Have an accurate measure of what their renal function is, and that'll tell you what their maintenance dosing is. The average renal function that they will have is likely to be different to a non-Indigenous person, though. And that's why referring to that 9 milligram is something which can be important. But, in truth, I think that as long as you know what the patient's renal function is, then you can use the same dosing. So if a patient had a creatinine clearance of 100 ml per minute, non-Indigenous or Indigenous, they would get the same dose of drug, which is, I think, what you're asking.
Yeah.
But it's assessing what that renal function is.
Hi, Jason. Michelle from Lady Salento Children's Hospital. Do you think that this data could be correlated to Indigenous pediatrics?
So I think that what it does, you can't extrapolate too much, but I think that the principles probably mean that renal function, again, most important thing to assess, and then body weight as well. With paediatrics, it's a little bit more difficult though, because the fat distribution that tends to be present in Indigenous patients is different to non-Indigenous patients. So the effect that's likely to have on milligram per kilo dosing in paediatrics, I think is a little bit less clear. But given that most of the time you'll be using total body weight, and if they are obese, then like a lean body weight type derivative, then I think that it's probably going to be the same as well. But in the absence of data, that's what my approach would be anyway, clinically.
Do we have any more questions, or we've got time for one more quick question?
Thanks very much, Jeff Shaw from Christchurch. Do you actually have a web-based calculator so that you can type all this in and you get all the answers back? Because I can't remember all your slides, you see.
Well, all the papers are published, and so we're always happy to share them with you. We've thought a lot about this, and it's something which we do want to do, is to develop an app not just for these patients, but all patients, whereby essentially you select the drug, renal function, or whether or not they're on renal replacement therapy, what the type of renal replacement therapy is, and it spits out what the dose is. We haven't got around to that yet. It certainly is the best way to translate these results and make them more findable for people and usable. Just got to try and work out how to play the medico-legal aspects of it and make sure that the lawyers would be happy with how we do it. But it certainly is something which would be a really important step.
I'd strongly encourage you to do that, because that is the translational gap. And I think what you presented is really great. But then when I go and do my ward round, it's kind of all leaked out of my brain and I can't remember. And I think that's probably true for everybody else.
Yeah, well, that's why pharmacists are important, because they really like this stuff, and they will remember it. And they don't have a quarter of the things that the medical staff and the nursing staff have to worry about as well. So,
thank you. Thank you.
Yep, we all need an app for that, don't we? All right, thank you then. So we'll move on to our next